Hello my dear friends. Our topic for presentation today is malignant melanoma. So malignant melanoma is a neoplasm of the melanocytes. Melanocytes arise from the stratum germinatum or the stratum basale of the skin. So why learn this topic? Because only 3% of the skin cancers are melanoma, whereas 65% of the deaths due to skin cancers are caused by melanoma. Only surgery is effective. Chemoradiotherapy is not very effective in case of malignant melanoma, but it is curable in early stages. So, detection of malignant melanoma early. When will a mole becomes a melanoma? We have to understand that. So, we should learn about this. If we miss this, the patient is doomed. We will go through the epidemiology, the risk factors of melanoma, clinical presentation of melanoma, diagnosis of melanoma, pathology, staging. Then we will go for the treatment of the primary melanoma, the lymph nodes, the non-nodal regional spread of melanoma, and the metastatic melanoma. First, regarding the epidemiology of melanoma. Melanoma, we can see a higher incidence in North America and Russia, whereas a lower incidence in Africa and India. So, it is more common in the Caucasians, the northern part. The risk factors of melanoma: blonde eyes, redhead, blue eyes, blonde, redhead, blue eyes, older patients and male gender, exposure to ultraviolet radiation, sunburn. All these are risk factors of melanoma. We'll come one by one. Blonde or redhead with blue eyes. In white people, the chance of melanoma is more. Older patients are at higher risk of a melanoma. Male gender is also at a higher risk of melanoma. The lifetime risk of males is 1.5 times more than female. Exposure to ultraviolet radiation. Ultraviolet radiation, sunburn from UV rays can also cause melanoma. Depending upon the degree of burn, sunburn can be first degree, second degree, or a third degree burn. Sunbathing for tanning is also a risk factor for melanoma. Indoor tanning devices, another risk factor. Benign navy and freckles have more chance to have melanoma. Family history of melanoma, there is increased chance, 3 to 7% increased risk of melanoma. Atypical mole melanoma syndrome, multiple moles, more than 5 moles are seen in the body of the patient. Previous history of malignant melanoma. So, these are all the risk factors of melanoma. Now, which population has the highest incidence of melanoma? African Americans, American Hispanics, Caucasians, Asian Americans. We know that is more common in the northern part. So, in the North America and Russia, it is more. So, the Caucasians, the answer is the Caucasians. What increases the risk of melanoma in white patients? We have already seen the picture. Dark hair and dark eyes? No. Fair complexion, red and blonde hair? Yes. Tanned skin, olive skin? No. So, fair complexion, red or blonde hair and blue eyes has increased risk of melanoma. What is the risk of developing a melanoma for individuals with a personal history of melanoma? There is a 3 to 7% increased chance of developing melanoma with a personal history, previous history of melanoma. From where can melanomas originate in individuals with atypical mole melanoma syndrome? In case of a normal mole, there is an increased chance for melanoma. Whereas from a normal skin, there will not be any increased chance for melanoma. But in case of an atypical mole melanoma syndrome, there is increased chance both from the normal skin and from the dysplastic nevi. Not only from the dysplastic nevi, but both from the normal skin and the dysplastic nevi. Answer is C. Now coming to the clinical presentation of melanoma. The clinical presentation of melanoma are asymmetry, border irregularity, color variegation, diameter greater than 6 mm and evolving lesions. ABCD: asymmetry, border irregularity, color variations. There can be different brown color, light gray color. All these color can be seen in melanoma. It's called color variegations, diameter greater than 6 millimeter, and evolving means there can be ulceration, it can be enlarging lesions. All those lesions are evolving. If there is an evolution of the lesion, it is a feature of malignant melanoma. Coming to the diagnosis. Melanoma, for the pathological diagnosis, we have to take the biopsy of the lesion. The different options available for us are incision biopsy, excision biopsy, punch biopsy, and shave biopsy. Which one will we use? This is the incision biopsy. A part of the lesion is taken along with the normal skin. From this we can see the depth of the melanoma can be assessed. Another one is excision biopsy. This is the best kind of biopsy. We can remove the whole of the lesion for biopsy. Another one is punch biopsy. Again we can see the depth, he can assess the depth here. With the help of a punch, a cylinder of tissue is removed so that we can assess the depth of the melanoma. Then we have the shave biopsy. The shave biopsy, there is if it is a deep shave, it is okay, but generally shave biopsy, we can only get a superficial shave and we cannot completely assess the depth of the tissue. So shave biopsy is generally not recommended in case of melanoma. So suppose we have a lesion, how will we decide which biopsy to take? Suppose the lesion is removable. If the lesion is very small and if it is removable by a punch biopsy. So if the lesion is removable by a punch biopsy, if it is a yes, then we can go for a punch biopsy because it will act as an excision biopsy. Now if the lesion is not removable by punch biopsy, then we have to think after removing the lesion, there will be a defect in the skin. Will it require, can it be primarily closed, or will we need a skin graft or a flap or something like that? That is, whether the reconstruction may be required after excision. If the answer is yes, the reconstruction will be required, then we can take an incision biopsy, confirm that it is a malignant melanoma, then excise the lesion and plan for reconstruction. If it is a comparatively smaller lesion where reconstruction will not be required, then we can completely remove the lesion. Then we can go for an excision biopsy. So if reconstruction is required and it is a large lesion, it is incision biopsy. If the reconstruction is not required and it is a small lesion and it can be closed by primary closure, excision biopsy. If it is a very small lesion, punch biopsy, because punch biopsy will act as an excision biopsy. Now, it is not only the primary tumor, lymph nodes has to be also assessed in case of melanoma. So we have to take an FNAC of the lymph node. Image guided, ultrasound guided FNAC is the best for lymph node assessment. So which biopsy technique is generally preferred for the accurate pathological evaluation of the lesion? Shave biopsy, excisional biopsy, incisional biopsy, fine needle aspiration biopsy. FNAC is for the ultrasound guided FNAC is for lymph nodes. Shave biopsy cannot completely assess the depth. When comparing incisional biopsy and excisional biopsy is a preferred method. When performing an excisional biopsy, what type of incision is often used to facilitate the closure? In excision biopsy, an elliptical incision is best. Circular incision, linear incision, no. It is an elliptical incision is the best for excision biopsy. What margin of normal appearing skin is typically taken with the specimen during an excisional biopsy? 0 to 1, 1 to 3, 3 to 5, 5 to 10. Generally, the margin preferred is 1 to 3 millimeter in case of an excisional biopsy. Why is shave biopsy generally discouraged when diagnosing melanoma? It is more painful than other biopsy methods? Not necessarily. It is more expensive? Not necessarily. It may result in incomplete assessment of tumor thickness. It is more time consuming? No. It may result in incomplete assessment of tumor thickness. The answer is C. Which biopsy technique is generally preferred for diagnosing nodal or other melanoma metastasis? Shave biopsy, excisional biopsy, incision biopsy, image guided fine needle aspiration biopsy. Nodal metastasis. So that is image guided fine needle aspiration biopsy. Now coming to, suppose we have sent the biopsy. Now, what is the pathological viewpoint of it? What does the pathologist see, or what is the pathology of melanoma? The first question they ask is it a simple mole or is it a melanoma? So, for that, routine staining may not completely, routine staining with hematoxylin and eosin may not completely help. To confirm it, we have to go for an immunohistochemical staining. Immunohistochemical staining are S100 staining for melanoma. It is highly sensitive for melanoma. More than 90% of the lesions may be stained by S100 staining in case of melanoma. But the problem is both the granular cell tumor and the schwannoma, nerve sheath tumor, can also take up the S100 staining. Then how will we differentiate it from a melanoma? For that, we have to go for a more specific stains. More specific stains, one is HMB45 marker in melanoma. The advantage, this is a HMB45 staining. HMB45 staining has another advantage, it can also assess the mitotic rate in case of a melanoma. Another one is anti-MART1 staining in melanoma. So this can also be assessed. This is another specific stain in case of melanoma. So now we have understood what is melanoma. What else should we know? But pathologists can also look whether it is an excision biopsy, whether the deep margins are involved, whether the peripheral margins are involved, and what is the thickness of melanoma. All this can be assessed. What else? The pathologist also wants to know the Breslow's thickness, whether the melanoma is ulcerated or not, whether the peripheral and deep margins are positive, mitotic rate of the melanoma, histological subtype, whether there is lymphovascular invasion, and whether there is tumor infiltrating lymphocytes. These are the other things which pathologists want to know. Now, what is Breslow's thickness? To how much depth the melanoma has gone in. So, if it is Breslow's thickness, it is T1, T2, T3 and T4 like lesions. So, if it is less than 1 mm, it is stage 1, 1 to 2 mm stage 2, 2 to 4 mm stage 3, and more than 4 mm it is stage 4. So, it is measured from the layer stratum granulosum in the skin. From the stratum granulosum, to how much depth it is there? Less than 1 mm stage 1, 1 to 2 mm stage 2, 2 to 4 mm stage 3, and more than 4 mm stage 4. Now, earlier it was Clark's level depending upon the layers of the skin. Clark's level has more of a historical importance. Now, for TNM staging, Breslow's thickness, which is more standardized, is used. So, we have to learn about Clark's level. If only the epidermis is involved, so skin has different layers like epidermis, papillary dermis, reticular dermis, and the subcutaneous tissue. If only the epidermis is involved, it is the stage 1. If it is involving the papillary dermis, it becomes stage 2. If it is involving the papillary reticular interface, that means this is the reticular, the blue one is the reticular dermis, and this is the papillary dermis. So, the papillary dermis has dipped into the reticular dermis, and the reticular dermis is pushing into the papillary dermis. This hill and valley area, this area is involved, it is the stage 3. So, papillary reticular interface is involved, it is the stage 3. If the proper reticular dermis is involved, it becomes stage 4, and if the subcutaneous tissue is involved, it becomes stage 5. So, that is the different Clark levels in case of melanoma. Now, coming to the histomorphological subtypes of melanoma. They are superficial spreading, nodular melanoma, lentigo-malignant melanoma, acral lentiginous melanoma, and amelonotic melanoma. Because if there is a histological variation, there can be also morphological variation in case of a melanoma. So, how the melanoma appears outside is related to the histology. So, this coming to the difference. Superficial spreading. So, which staining method is primarily used in the pathological analysis of melanoma? We know the different immunohistochemical staining. So, before that, which staining is used? Gram staining, PAS staining, hematoxylin eosin staining, and Giemsa staining. The most commonly used is hematoxylin and eosin staining. Which two antibodies are widely used in the immunohistochemical evaluation of melanoma? CD20 and 30, S100 and HMB45, CK7 and CK20, CD4 and CD8. Answer is S100 and HMB45. S100 is highly sensitive and HMB45 is highly specific. Which major histomorphological component is used to measure the thickness of melanoma? Clark level, Breslow's thickness, TIL presence, and regression. Clark level and Breslow's thickness can be used, but Breslow's thickness is now more commonly used and used in TNM staging. What is the specific use of monoclonal antibody HMB45? What is the use of HMB45 stain? Identifying dendritic cells, staining normal tissues, confirmatory stain for proliferative melanocyte cells and melanoma, evaluating non-melanocyte tumors. Of course, it can also help in assessing the mitotic rate in melanoma, HMB45. So it is for the confirmatory stain of proliferative melanocytic cells and melanoma. Now coming back to the histomorphological subtypes. First one is the superficial spreading. It is the most common. 70% of the melanoma are superficial spreading type of melanoma. They arise from the pre-existing nevus. That is, the superficial spreading means the horizontal growth is more than the vertical growth. Next is the nodular melanoma. It is the second most common of melanoma. 15 to 30% of melanomas are nodular melanoma. They are quickly invasive. That is the importance of nodular melanoma. Maligna melanoma. They are seen in sun-exposed older white women and they are generally present as larger lesions. Acral lentiginous melanoma. They are seen in darker skin patients, more commonly seen in the acral areas, in the distalmost areas, in the palms, soles and nails. Amelanotic melanoma. In amelanotic melanoma, there is no pigmentation. It is difficult to diagnose. Fortunately, it is rare. Which type of melanoma constitute the majority of melanoma? More than 70 all is nodular melanoma, maligno melanoma, acrolentiginous, superficial spreading melanoma. More than 70% of melanoma is superficial spreading melanoma. Answer is D. Which type of melanoma is classically located on the faces of older white women? Acrolentiginous, nodular melanoma, maligno melanoma, amelanotic melanoma. Melanotic melanoma is rare. Nodular melanoma, quick invasiveness, acrolentiginous, distalmost part, maligno melanoma, older women, sun-exposed areas, face. Acrolentiginous melanomas are more common in which group of patients? Almost all other melanomas are common in white patients except the acrolentiginous melanoma, which is more common in darker skinned patients. Darker distal acrolentiginous. Coming to the genetics of melanoma. We have already told about the family history. So, the genetics comes there, no? So, there are different mutations, BRF, KIT, NRAS, HRAS, GNAQ, PTN, TRT, NF1, ARID, CDKN2A. All these, the first four ones, BRF, KIT, NRAS and HRAS are more common, over which BRAF is the most common mutation associated with the melanoma. Forget everything, but don't forget BRAF. TNM staging melanoma. So TNM staging is special for melanoma because T staging is based on the thickness, not on the size measured by the tape. Clinical assessment of by tape. It is a pathological assessment. T staging by the Breslow's thickness. N stage is not the nodes alone. There are other forms of regional spread of melanoma. M stage is not by metastasis alone. In M stage, there is M1, A, B, not just M1, it is M1A, M1B, M1C, and M1D. And there is also enzyme levels coming to play and one enzyme level is also coming into play in case of a metastatic staging in case of melanoma. So coming to T stage, all these are seen. Let us simplify it. Coming to Breslow's thickness, less than 1 mm, T1, 1 to 2 mm, T2, 2 to 4 mm, T3, more than 4 mm, T4. Then what is T1A? We can also see this T1A and T1B. That is on ulceration. A non-ulcerated lesion is A. So T1A lesion is a less than 1 mm non-ulcerated melanoma. T4B lesion is more than 4 mm thick ulcerated lesion. So A is no ulceration, B is ulceration. Coming to the end stage in melanoma, of course, there are regional lymph nodes. If regional lymph nodes are positive, it is end stage is positive. But there are other forms of regional metastasis. Which are they? They are the in-transit metastasis, satellite lesions, and microsatellite lesions. Coming to each one of it. What is in-transit metastasis? So from there is a primary melanoma, and from this the melanoma is going to spreading to the lymph nodes. But in between, during the pathway to the lymph node, through the lymph vessels, it also get deposited in the deposited to the skin. So that is called the in-transit metastasis. It has started from the primary lesion. It has not yet reached this lymph node. In between, it spreads in the skin. That is called an in-transit metastasis. To call one black lesion near the melanoma an in-transit metastasis, it has to be more than 2 centimeter away from the melanoma. It has to be more than 2 centimeter away from the primary melanoma, and before it reaches the nearest lymph node. So that is in-transit metastasis. What is a satellite lesion? We said in-transit metastasis is more than located more than 2 centimeter away from the primary lesion. In satellite lesion, it is located within 2 centimeter of the lesion. But we should be able to see with naked eye. It can be seen without a microscope within 2 centimeters. And then what type of lesion is seen with a microscope? That is microsatellite lesions. It cannot be seen with naked eye. They are microsatellite lesions which are seen with a microscope. They are microscopic nests, and it should be more than 5 mm in diameter. This is a view by microscope. A microsatellite lesion is here. Should be separated from the primary lesion by a normal dermis, and it should be more than 0.05 millimeter in diameter. So that is a microsatellite lesion. So other than lymph node, the regional spread can be in-transit metastasis, microsatellite lesions, and satellite lesions. So all this come to the end stage, regional metastasis. So we can see everything. Seems confusing. Let us try to simplify it. So N there can be, you can see here there is N1, N2 and N3. In everything there is N1A, N1B, N1C, N2A, N2B, N2C, N3A, N3B, N3C. So let us try to simplify. N1A, N2A and N3A. This dot is a clinically occult node. That is, the node is pathologically positive but clinically not palpable. This bigger dark spot is a clinically positive node, clinically palpable node. And this square is in-transit metastasis, satellite lesions or microsatellite lesion. That is non-nodal metastasis. So N1A is a clinically occult single node is positive. It is called N1A. So then a question, okay, that will come. Then a question comes: how will we understand a clinically occult lymph node? Clinically occult lymph node is by sentinel lymph node biopsy. We put in a blue dye in the melanoma, and we cut open the nodal basin and see whether there is a sentinel lymph node is there, whether there is a blue dye, it is seen in the node, and that node is sent for pathology. If that node is positive for a melanoma, there is a melanoma spread in that node, that is a clinically occult node, a node which is not palpable, but it is holding melanocytes, malignant melanocytes in it. So that is a clinically occult node. So that is how we understand a clinically occult node. So in sentinel lymph node biopsy, if one node is positive, it is N1A. If two nodes are positive, is N2A. If 4 or more nodes are positive, clinically occult nodes are positive, it is N3A. Coming to N1B, if it is a clinically palpable single node is positive, it is N1B. A node is clinically palpable, but two nodes are positive. Either it can be clinically occult, or one of which can be clinically occult or clinically palpable. So that is N2B. And if one node is palpable, but 4 or more nodes are positive in case of a sentinel lymph node biopsy. One node should be palpable. Then it becomes N2, N3B. N3C, no lymph node, but there is an intransite metastasis, microsatellite lesions, or a satellite lesion. In N2C, a node is positive, either a clinically palpable node or a sentinel lymph node is positive. Along with that there is a non-nodal metastasis. And in N3, two or more nodes are positive, and there is, in a two or more nodes are positive, either it can be clinically palpable or not, and a non-nodal metastasis like intransit, satellite or microsatellite is present. So that is regarding the nodal staging. Sentinel lymph node biopsy. The dye used can be isosulfan blue, lymphosurin blue, or it can be methylene blue. Isosulfan blue is more commonly used. Now metastasis is also special. M1 does not M1. M1A is skin or non-regional lymph nodes. M1B is lung involvement. M1C is other visceral involvement, and M1D is CNS involvement in case of metastasis. It is not yet over. In M1 also we can see a 0 and 1 here. So M1C 0 and 1, M1D 0 and 1, M1B 0 and 1. 0 means we have to check for the LDH levels. LDH level is not elevated, it is 0, and LDH level is elevated, it is 1. Now, coming to questions. A patient present with melanoma, thickness of 1.5 millimeter, no ulceration. What is the pathological T stage? So, it is melanoma is basically pathological staging. So, PT stage. So, it is breast loss depth. It is 1.5 millimeter. So, it is 1 to 2 mm. So, it is PT2. With ulceration or without no ulceration. So, it is PT2A. PT2A without ulceration. A patient present with has melanoma with a thickness of 4.5 mm without ulceration. So 4.5 mm more than 4 mm. So it becomes pathological T4 without ulceration. So it becomes no ulceration is A, without ulceration is PT4A. A patient has a distant metastasis to the lung with elevated LDH stage, LDH levels. What is the M stage? So it is lung. M1B, we know this M1B is lung. So LDH level is elevated, it is 1. LDH level is elevated, it is not, it is 0. Not elevated, 0. Elevated, 1. So here it is elevated. So it is 1. M1B 1. Answer is M1B 1. A melanoma patient has 4 or more clinically detected nodal metastasis with no in-transit satellite or microsatellite metastasis. What is the PN stage? So there is more clinically detected nodal metastasis. So we can see this. There is 4 or more clinically detected nodal metastasis. There is no in-transit metastasis, but there are clinically detected nodal metastasis 4. So that becomes N3B. So it is N3, it is B, N3B. A melanoma patient has 1 clinically detected nodal metastasis with 1 in-transit metastasis. What is the PN stage? 1 clinically detected nodal metastasis and 1 in-transit metastasis. So it becomes N2, it is C. So answer is P, N2C. So based on this, there can be pathological and clinical staging into stages into 1A, 1B, 2A, 2B, 3, 2C. Not easy to remember all this, but we have to understand that if it is stage 3, if there is node involvement, there is stage, it becomes stage 3. If there is node involvement, it becomes stage 3. So a patient has melanoma with distant metastasis to the lung. What is the stage? What is the stage group? Whenever there is metastasis, it becomes stage 4. A melanoma patient with 4.5 mm thickness, with ulceration, with multiple nodal metastasis, clinically detected, and no distant metastasis. So whenever, what is the stage group? Whenever node is involved, it becomes stage 3. Node is involved, it becomes stage 3. A melanoma is 0.7 mm in thickness without ulceration with 1 nodal metastasis, clinically occult. No distant metastasis present. What is the stage? So whether the nodal metastasis, whether it is clinically occult or clinically palpable, doesn't make a difference. If there is nodal metastasis, it is stage 3. Now coming to the treatment of melanoma. There can be treatment of primary tumor. We can discuss the treatment of primary tumor is wide excision with margin. We have to remove the tumor with a margin. What is the margin used? If it is a thickness, it is based upon the Brussels thickness. If the tumor is less than 1 millimeter thick, 1 centimeter margin. If it is 1 to 2 millimeter thick, 1 to 2 centimeter margin. If it is 2 to 4 millimeter thick, it is a 2 centimeter margin. There is no point in increasing the margin more than 2 centimeters. So, even if the lesion is more than 4 mm thickness, it is 2 centimeter margin itself. Now, treatment of primary tumor, reconstruction of melanoma. We can excise the tumor. How will we have to get a skin cover? How will we reconstruct? Primary closure is the preferred method, but if it is in the face, it can distort. If it is a larger melanoma, there can be distortion of the face or the facial features. Then we have to think of other methods of other reconstruction methods. Generally, we use an elliptical incision with a 3 centimeter 3:1 length to width ratio is required for closure. So whenever we put an elliptical incision, 3 length 1 width, that should be the ratio. Suppose in case of a smaller lesion, primary closure can be attained. But what do we do in a case of a larger lesions? There we have to go for a skin graft. Suppose it in the lesion of the extremity, where cosmesis is not much of a problem, we can go for a split thickness graft. Advantage of split thickness graft, we can mesh the graft like this and cover a larger area. But what if the melanoma is in the face? Then we have to go for it is of cosmetic importance, then we have to go for a full thickness graft. Here is a full thickness graft taken. Now, suppose sometimes we have to go for a local flaps. If they were best for head and neck and extremities defects, local flaps can be used instead of primary closure. You can see a melanoma in the face where a local flap is used. Suppose if there is no adequate tissue for local flaps, then sometimes we may have to take a free flap along with the vascularity of the tissue, along with the vessel, and thus this vessel can be anastomosed with the vessel locally, and we can go for a vascularized or we can go for a free flap. So these are the different reconstructive options in case of melanoma. So what is the preferred method for closing of most lesions in case of malignant melanoma? Always primary closure is the best method. For primary closure, what is the usual length of longitudinal axis of an elliptical incision relative to its short axis? Twice the length, 3 times the length, 4 times the length, equal to the length. We have already said that the best ratio is between the length and the width is 3:1 ratio. The answer is B, 3 times the length. From where should a split thickness skin graft for the lower extremity in primary lesions should be harvested? The question means that if there is a malignant melanoma in the right leg, say suppose in the right leg, near the gastrocnemius region, posterior part of right leg, from where will we take a skin graft? From the right leg or from the left leg? From the ipsilateral leg or from the contralateral leg? The answer is we will take the graft from the contralateral extremity. Why? Because of the in-transit metastasis. In the same leg, there can be in-transit metastasis. So, if we take so it is generally preferable in case of a melanoma to take it from the contralateral extremities, to take into harvest the graft from the contralateral extremity. So, that is regarding the treatment of the primary lesion or the primary melanoma lesion. Now, coming to the treatment of the regional lymph nodes. So, when we treat the regional lymph node, the first question is whether the lymph node is clinically palpable or not. If it is clinically palpable, then we can take an ultrasound guided FNAC from that. If the FNAC is positive, it means that the lymph node basin is affected. We have to go for a formal lymph node dissection. Suppose what happens if the ultrasound guided FNAC is negative, then we have to completely, the next assessment for the nodal basin is the sentinel lymph node biopsy. So, ultrasound guided FNAC is negative, then we have to go for the sentinel lymph node biopsy. But what will we do if the nodes are not palpable? In case of a upper limb, say right hand, there is a melanoma. We can assess the node from axilla. We know that the sentinel lymph node will be in the axilla, so sentinel lymph node biopsy can be done from axilla. In case of a right lower limb or the left lower limb, the sentinel lymph node will be in the left inguinal region. So we can assess the sentinel lymph node. We can take sentinel lymph node biopsy from the lymph node. But suppose the lesion is in the chest wall, or suppose this lesion is near the umbilical region. What will we do? How will we know which is the sentinel lymph node? The sentinel lymph node near the umbilical region can either be the inguinal node or it can be the axillary node. If more towards the midline, it can be on the right or the left. We don't know which is the sentinel lymph node. In that case, we have to go for a lymphoscintigraphy. What is lymphoscintigraphy? We inject a dye to the melanoma, inject a radioactive dye to the melanoma, and this from that dye will go into the sentinel lymph node, and from that we can, with the nuclear scan, we can take a scan, and we can identify where the sentinel lymph node is there. And from that we can identify the sentinel lymph node. Suppose the lesion is in the abdomen, we can take a lymphoscintigraphy and see which node is involved. If the inguinal node is involved, then we can go take a sentinel lymph node biopsy from the inguinal area. If the axillary node is involved, then we can take a sentinel lymph node biopsy from the axillary area. If both the inguinal lymph node and the axillary lymph nodes are involved, then we have to take sentinel lymph node biopsy from both those areas. So that is regarding, so after lymphoscintigraphy, then we can go for a sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, then we know that the lymph node basins are not involved, and then we can go for a conservative management. No need for lymph node dissection. If the sentinel lymph node biopsy is positive, it means that the lymph node basin is involved, and we have to go for a formal lymph node dissection, whichever lymph node basin the sentinel lymph nodes were positive. Which substance is commonly used as blue dye in sentinel lymph node biopsy? Methylene blue, lymphosurin, isosulfan blue, all the above. All these can be used. Isosulfan blue is more commonly used. Methylene blue and lymphosurin can also be used in case of sentinel lymph node biopsy. What might affect the accuracy of sentinel lymph node biopsy if performed after biodexation? Use of blue dye doesn't affect. Preoperative lymphoscintigraphy. Preoperative lymphoscintigraphy actually helps to increases the accuracy of sentinel lymph node biopsy. Use of radiocolloid also helps to increase the accuracy of sentinel lymph node biopsy. Extensive reconstruction of primary melanoma site. It does not help. Why it decreases the accuracy? This means that before reconstructing the melanoma or before excising the melanoma, we have to take the sentinel lymph node biopsy. So once we excise and reconstruct a melanoma, then we go for sentinel lymph node biopsy. Then we will not understand. So the part which is draining will be different. So if there is reconstruction, we have to take sentinel lymph node biopsy before we excise the melanoma. The treatment of non-nodal regional disease. So we have understood the treatment of the primary disease. We have understood the treatment of the regional lymph nodes. Now what is the treatment of non-nodal regional disease, which includes the in-transit metastasis, the satellite lesions, and the microsatellite lesions. The satellite lesions which occur within 2 cm and the microsatellite lesions which can only be in microscopy is not much of a big problem, because we can excise it along with the primary tumor. But in-transit metastasis is a different story. We have to treat it in a different way. It can be, if it is a small or single in-transit metastasis, we can go for a surgery and remove the lesion. If it is widespread and it cannot be managed by any regional approaches, we can go for systemic therapy. But generally, the treatment of in-transit metastasis is regional approaches. The regional approaches are hyperthermic isolated limb perfusion, isolated limb infusion, and intralesional therapy. Hyperthermic isolated limb perfusion. In case of hyperthermic isolated limb perfusion, a surgeon is required, a perfusionist is required, and a complex machinery like a heart-lung machine is also required. So what is happening there? So, this is a setup. It is 1950s. In 1950, this has been identified for extremity metastasis. It isolates the limb with extracorporeal bypass and tourniquet. So, let us see what happens. How that limb is bypassed from the general system and a high dose of chemotherapy is given. So, what happens? An incision is made. Suppose the lesion is in the leg and in-transit metastasis are in the leg like this. The melanoma is in the leg here and the in-transit metastasis in the lower limb. An incision is made in the inguinal area and the femoral artery and the femoral vein is identified, and into it the catheter is being passed. The proximal area is clamped with the non-crushing clamps. The catheter is vascular catheter is passed like this, and from the vein all the blood is sucked out. From the vein all the blood is removed to the venous reservoir with the help of a rotary head pump, and that blood is oxygenated like a heart-lung machine. That blood is oxygenated, and during that time and after that time it is pumped back into the artery, and in between that time in that arterial line we put in the chemotherapeutic agent. The chemotherapeutic agent is we are putting into that in the high dose is melphalan, TNF alpha and IFN gamma, interferon gamma. All these chemotherapeutic agents can be used in case of a high isolated limb perfusion. Melphalan is the most commonly used. Then it is pushed back into the arterial line. So, melphalan effectiveness is high. The response rate of 64 to 100% is seen in melphalan. Median complete response is 58%. Isolated limb infusion, but we can see that it is a complex procedure. Machinery, perfusionist, surgeon, everything is required. So, isolated limb infusion is developed to simplify this procedure. Now, what is isolated limb infusion? In isolated limb infusion, instead of an incision, we are putting a catheter. So, with the help of a radiographic guidance, with the help of an ultrasound guidance, we are putting an arterial and venous catheter into it. Now, how will we cut off the limb from the rest of the body? We put in a tourniquet. So, it is a low flow, minimally invasive limb perfusion uses percutaneous catheters, not any bypass. Now, there is no oxygenation. In other part we have seen in limb perfusion there was a membrane oxygenator. Here there is no oxygenation, and the cytotoxic agents are infused into the line, and we can see that cytotoxic agents are infused into the venous line itself. Chemo is infused into the arterial line. How the blood from the vein is pulled, it is using due to the syringe. Through the syringe it is pulled out and it is pushed through a syringe. So, it is a hand circulated, and the duration of this chemotherapy is 20 to 30 minutes. No oxygenation, cytotoxic. What is the advantage of no oxygenation? Does it means that this is less useful? No. Due to the hypoxic atmosphere, due to no oxygenation, it enhances the cytotoxic effects and enhances the cytotoxic effects of the chemotherapy and increases the tumor cell damage. Now, which agent is currently the most actively used for limb perfusion? Hyperthermic isolated limb perfusion. Already said melphalan. Melphalan is the most commonly used. What is the primary difference between isolated limb infusion and isolated limb perfusion? Isolated limb infusion uses a heart-lung machine. No, isolated limb infusion was brought to simplify the circuit. So, it does not use a heart-lung machine. Isolated limb perfusion, hyperthermic isolated limb perfusion uses a heart-lung machine. Isolated limb infusion involves surgical insertion of catheters. No, it is radiography guided insertion of the catheter in isolated limb infusion. Isolated limb infusion uses radiation therapy instead of cytotoxic agents. False. Chemotherapeutic agents like melphalan is used. Then what is the correct statement? Isolated limb infusion is performed without oxygenation of circuit. In case of isolated limb perfusion, there is a membrane oxygenator. In case of isolated limb infusion, there is only a heat exchanger. There is no oxygenation in the circuit. What is the range of overall response rate achieved with hyperthermic isolated limb perfusion using melphalan? We have already said is 64% to 100%. How long is the limb typically exposed to the cytotoxic agent during isolated limb infusion? The duration is low, it is 20 to 30 minutes. So sometimes some of the solution, in extremities we can do this isolated limb perfusion and hyperthermic isolated limb perfusion and infusion, isolated limb infusion. What if the in-transit metastasis is in the trunk? What will we do then? We can either go for a chemotherapy. Another option is intralesional therapy. Intralesional therapy can be done by different agents. It directly targets the lesion by injection into the lesion, and it has limited systemic toxicity because of the direct injection. The different agents used are BCG therapy, PV10 and TVEC. So what is BCG? It is early significant tumor regression when caused, but there are severe toxicities for BCG. PV10 is 10% Ross Bengal, induces intratumoral necrosis. TVEC, it is an oncolytic virus, increases durable response rate. So when we give TVEC, it is not a chemical destruction. What happens is the virus goes into the tumor cells and destroy the tumor cells. So what is the mechanism of action of talimogene laharparepec, TVEC? That is easier to pronounce, TVEC. A. Direct oncolysis from viral infection and lytic replication. Inhibition of angiogenesis, false. Blocking of epidermal growth factor receptors, false. Enhancing DNA repair mechanism, no, it destroys the DNA. So answer is direct oncolysis from viral infection and lytic replication. Why do you say direct oncolysis? In direct oncolysis, the tumor cells are the virus is injected. It goes inside the tumor cell and destroy the tumor cell. That is direct oncolysis. There are another method for indirect oncolysis, where the virus goes into the tumor cells. It does not destroy the tumor cells by itself, but it attracts the immune system, and the immune system come and destroy the tumor cell. That is indirect method. The TVEC causes direct oncolytic mechanisms. Historically, which agent was one of the first used for intralesional therapy in melanoma? All these are new except BCG. BCG, TB historically, Bacillus calmette-guerin is used for, which is historically the first agent used for intralesional therapy of melanoma. So we have told about the treatment of primary melanoma, treatment of the nodes, treatment of the non-nodal metastasis like in-transit metastasis. Now coming to the metastatic melanoma. What will we do regarding the metastatic melanoma? So the most commonly used drug is dacarbazine. It is a standard drug, but see the response rate. It is very low, 16% response rate. Other agents can also be tried. Cisplatin, paclitaxel, docetaxel, and temozolomide can also tried. It shows some activities, but not much of a benefit from chemotherapy in case of malignant melanoma. Then what will we do? We have to go for other chemotherapies like targeted therapy. What is targeted therapy? Specific molecular targets which helps to disrupt the tumor growth are used. What are these molecular targets? Here we use the genetics. We use the BRF, NRAS, all that we use. So BRAF inhibitors like vemurafenib, dabrafenib, they target BRAF V600E mutation. Another one is MEK inhibitors. Trametinib targets downstream MAPK pathway, and combination therapy. What does all this mean? So let us see how the normal cell growth happens. The growth factors act on epidermal growth factors receptor, and they activate the RAS system. They have then the BRAF pathway comes into play. MEK comes into play. Then ERK comes into play, and normal cell growth happens. In case of a melanoma, this BRAF is mutated. So there is high stimulation of MEK, high stimulation of ERK, and stimulation of the cancer cell growth producing melanoma. So if we give a BRAF inhibitor like vemurafenib and dabrafenib, it is blocked here. We can also give an MEK inhibitor like trametinib, which blocks at the MEK. So these are the drugs which can be used for targeted therapy in case of malignant melanoma. Coming to another method is immunotherapy. What does immunotherapy do? It enhances the host's immune response to cancer. So the immune method, if the host identify the cancer cells of melanoma as foreign, they can destroy the melanoma. So the host immune response is used to treat the melanoma in case of immunotherapy. One is interleukin 2. It promotes immune cell proliferation and produce durable response. Interleukin 2 is given, the total immunological system becomes activated. So it can help, but it has side effects also. Then checkpoint blockade. There are two blockades, CTLA4 and PD1 blockade. For CTLA4, ipilimumab is used, and for PD1 blockade, nivolumab and pembrolizumab are used. And both these can enhance T cell response. There are also some tumor vaccines. So, what is this checkpoint blockade? So, this is this interleukin 2. It signals, it acts on every immunological cells. The activated B cells, natural killer cells are activated, T cells are activated, monocytes are activated. Everything is activated when interleukin 2 is given. But the side effects are also like that. So, that is the problem with interleukin 2. Now, what is the CTLA4 checkpoint blockade? The antigen presenting cells, this is a T cell, the blue one is a T cell, and this is the antigen presenting cell. The antigen presenting cells shows the antigen to the T cell receptor. So, what will happen? The T cell will go and destroy the melanomatous cells. Suppose the melanoma cell is the antigen, malignant melanoma cancer cell is the antigen. So, T cell will go and destroy the melanomatous cell. But there is also a checkpoint. The checkpoint is the CTLA4 will normally say that, oh, don't go T cell, be peaceful, don't destroy that antigen. That it is similar to the our normal cell. So the antigen presenting cell will say to the T cell, go and kill the melanoma. CTLA4 will whisper into the ears of the T cell, don't go. So what will we do? So the T cell will not go. So if we block the CTLA receptor, if we block the CTLA4, then the T cell will go and destroy. So CTLA4 blockade, the ipilimumab blocks the CTLA4 checkpoint, and so that the T cell will enhance T cell activity will happen, and T cell will go and destroy the melanomatous cell. Now another similar mechanism is happening in the PD1 PDL1 receptor mechanism. So T cell comes to the cancer cell, and the cancer cell there is a tumor antigen, and the T cell receptor identify the tumor antigen. So the T cell will destroy, ideally it should destroy the tumor antigen. But the PDL1 will say to the T cell that, no, I am similar to the normal body region, don't destroy me. So the PDL1 or PD1 inhibitor, the PD1 inhibitor is nivolumab, and pembrolizumab is more of a PDL1 inhibitor. If it is inhibited, then the T cell has no inhibition. It destroys the cancer cell directly. So the next checkpoint is PD1 PDL1 checkpoint at the level of the cancer cell. Earlier it was at the CTLA4 checkpoint was at the level of antigen presenting cell. PD1 PDL1 is checkpoint is at the level of cancer cell. So these are the two immunological checkpoints which can be overcome with drugs and which can be used to destroy the cancer cells in immunotherapy. So which chemotherapy agent has historically been the standard care for systemic chemotherapy in metastatic melanoma? Again, cisplatin, paclitaxel, dacarbazine, temozolomide. Answer is dacarbazine, 16% response rate. Which immunotherapy agent promotes the proliferation, differentiation, and recruitment of T, B, and NK cell? All the cells, others are more targeted. All the cells are activated in case of interleukin 2. All the cells are activated, T, B, and NK cells. What is the mechanism of action of ipilimumab in treating melanoma? Promoting apoptosis of cancer cells? No. Inhibiting PD1 to boost T cell responses? Is it? Increasing production of cytokines, that is IL1, blocking CTLA4, key regulatory mechanism molecular. Which one it is, PD1 or CTLA4? Ipilimumab is blocking CTLA4, a key regulatory molecule of the immune system. What is the effect of PD1 interaction with its ligand PDL1 and PDL2? inhibits the function of B cells? No, it is regarding T cells. Increases the production of antibodies? No. Enhances T cell proliferation, dampens T cell response to limit autoimmunity. The PD1 PDL1 interaction actually dampens the T cell receptor, dampens the responses of T cell due to autoimmunity. Once the PD1 and PDL1 are inhibited, then the T cell will kill the cancer cells. PD1 and PDL1 normally, if they interact, PD1 and PDL1, if they interact, it dampens the T cell responses to limit autoimmunity. Which of the following is an MEK inhibitor used in treatment of metastatic melanoma? Pembrolizumab and ipilimumab is CTLA4. Pembrolizumab is PD1 PDL1 combination inhibitor. Nivolumab or trametinib. So we have know it is trametinib. Nivolumab is also the PD1 PDL1 blockade. So trametinib is the MEK inhibitor. Which of the following is a BRAF inhibitor used in the treatment of metastatic melanoma? Nivolumab, trametinib, dabrafenib, pembrolizumab. So BRAF, where does the BRAF? It is in here, dabrafenib. So answer is vemurafenib and dabrafenib causes blockade at the level of BRAF inhibitors. So dabrafenib, BRAF is here. Dabrafenib is the answer. So now we have discussed regarding the epidemiology of the melanoma, more in white people, risk factors of melanoma, the different, the sunbathing, everything, clinical presentation, the ABCDE in melanoma, diagnosis, the different types of biopsy and the different types of stains, pathology, the Braslow's thickness, the mitotic rate, everything, staging, the T, N and M staging, and the variations from the normal T and M staging. The treatment of the primary melanoma, excisions and reconstructions, the treatment of lymph nodes, sentinel lymph node biopsy and lymph node dissection, treatment of non-nodal regional spread by hyperthermic isolated limb perfusion and isolated limb infusion, treatment of metastatic melanoma by targeted therapy, immunotherapy and chemotherapy. That is regarding melanoma. Thank you.